Hi, everyone. We're interviewing John Marchica, who is an old friend of mine, having been on my podcast before, and I think I've been on his. And it turns out we have guitars in common, as you can see if you're watching the YouTube version here. We both have his office is on a golf course. I live on a golf course. We have lots in common beyond the healthcare stuff. So, welcome back, John. Good to see you.
Thanks for having me.
Oh, I love it. Les Pauls are the day, man. That's what we're going to talk about today, but not really. And we
Lo-
can put that into the conversation
We
later.
could weave in a little Les Paul and then a little talk about your keyboard over there. I have not made the jump to bring one of my keyboards into the office. I think I would probably drive everybody out if I did that.
Yeah, it's funny because my all my client calls, everybody brings up the guitar almost like, I don't know, at least 80% of the time somebody refers to it. Nobody brings up the keyboard. One person has, and it's a synthesizer. It's a good keyboard. It's not like a little plinky thing that my kids used to play when they were playing music. Anyway, so we're going to talk about something completely different. First of
Yep.
all, John, assuming that, the listeners today haven't all been 100% listened to the last podcast we did with you a couple of years ago during COVID. Tell us about Darwin Research Group. What do you do? And by the way, why is it Darwin? Let's start there.
Good question. So Darwin Research Group, we're based out of Scottsdale, and our sort of lens of focus, our research area of focus is in organized healthcare delivery systems of all types. We call them IDNs, big physician groups, big cancer centers, everywhere that somebody has decided to put all of this together under some kind of holding company. And we analyze those systems. And on the client side, not all, but most of the people that we work with are in the life sciences, who are trying to understand the changes in healthcare. So I kicked this off. I will get into a little bit of my background, I'm sure, with some of these questions, but I kicked off the LLC in 2010. So officially we're, I guess, almost 15 at this point. Although I will say the first 5 years, and if you go back to when you were starting, Stuart, you might remember the days, or who knows, maybe you just like, and then you have a company and all these
No,
employees
no,
and all
no.
this
It's a
money coming in.
long slog, baby.
It's a long slog, right? So those first 5 years was like, if I could afford to bring in somebody for part-time from some agency to help me out with a few things. So, but anyway, so that's our focus. I spend most of my time, if I'm not interviewing or talking to people in the space, it's reading about it, trying to understand and the changes. And one of the things that I just love about what I do, and I bet you would probably agree with me on what you do, is that the fact that there's so much change going on for so long, for as long as I can remember, it makes this kind of work interesting.
Yeah.
It's not like everything is boilerplate and you're just, same thing year after year after year. There's always something new because healthcare is so dynamic. So that part of it, I love.
I totally agree. And it's funny because, for us, we've had to reinvent ourselves multiple times. That's why we're all still here. And because we wouldn't be, right? We've changed our model multiple times. And yeah, it's wildly different than it used to be in the old days for us. And, I have a team now that I've always had good teams, and this one just is the smoking best team. Like it's amazing. But it's, okay, guitar analogy, metaphor, we'll bring that in right now.
All right.
Yeah, I'll tell you, like I use this with clients a lot and it's real. It's like good musicians play with other good musicians. And so I find that in marketing, the best talent wants to be with other good talent. And you can't, it's really hard when you're starting because like you may be really smart, but the talent wants to be with other talent besides just the founder. And
So
that's the
true.
thing. Yeah.
Yeah, it's so true. And then to your point about reinvention, so early on, um, our first sort of market research report, that you could buy off the shelf, was in home healthcare. And our second one, and I really thought this company was going to be all about ACOs and
Yep.
value-based care delivery, and like that's what people wanted to know about. And look, I know we're going to probably dive into that as maybe a topic to talk about, but um, it's still relevant. It's just that I feel like on the research side, at least in those early years, I was a little bit early on stuff. You know what I
Yeah.
mean? It's
Yeah.
like I saw, oh, this is going to be interesting. People are going to want to look at this and we're going to go down this rabbit hole. And then folks would say, yeah, well, home health, that hasn't really come into its own yet. It's still premature to talk about, that kind of attitude. And
Yeah.
it took us a while to kind of calibrate on, the integrated delivery network or the integrated health system as sort of being, I don't know, the unit of analysis, for lack of a better term, to try to sound smart. The unit of analysis is the IDN, and that's when we really took off.
That's
So
great.
it happens, right? I mean, you
Uh,
got to reinvent.
well, it's easy to be a pioneer, but then you get arrows in your back. So it's like, it's
True.
not, it's like, but it's also good to be there because later on it gets a lot harder. So just briefly, tell me a little about your background and how you came up with this idea. You mentioned earlier your background. I'm just curious prior to this, and we're going to jump straight into this in a second. But
Sure.
yeah,
So when I got out of school the first time, I cut my teeth at Abbott. So I was a pharma guy because the division that I was in later became AbbVie when they kind of split the company apart. Um, and I was there, and then from there, I had the entrepreneurial bug. You know what this is like, Stuart. So I had the bug, and I started a medical education company called FaxWatch that I ran for about 11 years, and then I sold it and went to go work on a PhD and in Dartmouth's kind of interdisciplinary program. And that's sort of important to the narrative today, I think, because had I not had that sort of pit stop for 5 years and where we were, in our doctoral seminars, like inventing value-based care models and testing them and kind of just going back and forth with other students, I probably wouldn't be doing what I am today. But that time that you know, I always joke about this. I say most guys, they have a midlife crisis, they buy a Corvette. Yeah, I went off and worked on a PhD, and you know,
poor guy.
poor guy.
I'm sure there's hope for you somewhere. Wouldn't the Corvette have been more fun?
The Corvette would have been way more fun, and I probably would have picked something even more fun than that. Maybe a Ducati or something. But anyway, um, I being exposed to that kind of thinking and like understanding where healthcare was going and looking at the economics, looking at the policy implications, looking at the outcomes and epidemiology, kind of clinical epidemiology, where we were going, the important areas to focus on. I just got it was on like that second wind you get,
I love it.
sometimes midway in life. And so starting this company, as I said, early on, it was trying to find our footing and what I wanted to focus on. But you know this, just because you want to focus on something, right? Leader going to get arrows in the back, right?
Yeah.
But it's really what the marketplace wants and what's most needed, what people are willing to pay for, what they want to know. And in this business, the biggest question, well, there's a bunch of question marks, but one of the biggest ones is, what about the integrated delivery network? What about this sort of model of care, and in some cases, model of payment as well? It seems like there's a lot of movement over the last decade or two in this area, a lot of mergers and acquisitions, some of the bigger getting bigger. Um, and it seems to be the place where, at least from the life sciences perspective, where they have the most questions and where there's a lot of change happening. And so that's where we ended up. I
Okay.
guess, the other way that I would describe it, sort of in a non-healthcare way, Stuart, is I get to write, I get to do talks and keynotes. I get to read a lot and like think about how and build models.
Yep.
Um, I've sort of constructed this company to do all the stuff that I like to do.
I love it. I
You know
love
what I
it.
mean? So it's
Yeah.
like it kind of worked out that Darwin and so by the way, you did ask about the name.
Yeah.
So the doing, I get to do a lot of what I like to do also, as you know.
Yeah.
You don't get away from doing some of the things you don't like to do just because you
Yeah.
don't like to do them. So there are those tasks as well. Um, but at the time when I go back to that sort of 2010 timeframe and having sold my company and working on a PhD, and I didn't mention marriage. The first marriage didn't go so well, so that one ended. and there was a lot of change. And so I was thinking about evolving, sort of like, what's my next step? Where am I going? And that word evolution kind of kept. So it's sort of a nod to that, even though I
I
don't
love
think
it.
that
Yeah.
that Charles Darwin, first of all, came a lot earlier, but he wasn't thinking about self-actualization and Maslow's hierarchy um, when he was talking about the theory of natural selection. But that's kind of stuck with me, and it kind of goes to your point earlier, which is about trying different things and reinventing yourself. Because if you don't, you die.
Yep, for
You don't
sure.
make it.
Absolutely. Natural selection. Awesome. Okay, so let's go into the you've mentioned the integrated delivery network, and I would love you to take a moment just to define that to some of the audience who may not be as familiar with that. And then I'd love to hear some of the common themes and trends that you're seeing.
Sure. So what I like to think of is I start with the premise of sort of a holding company, you know, um, of an entity that, and it can be in any different kind of industry, right? But just a holding company that has a lot of interest. And in the healthcare world, that sort of moniker IDN or integrated delivery network, it also means integrated health system. It means a lot of different things to different people. And it's kind of become this catch-all to describe something big that's delivering care. But really, it's a holding company where there are varying degrees of the ability to deliver care. So you might have a system that has a couple of hospitals and maybe a physician group, and they all are under the same umbrella. And the doctors in the physician group are referring to the hospitals for procedures, and maybe they're contracted or maybe they're even employed. And so that's an example of a small delivery system or IDN. And then you kind of go to the other spectrum and you look at an organization like a Kaiser or an Intermountain, or here in Phoenix, like a Banner, one of these organizations where they have not only the hospitals and the physician groups, but they might have a home healthcare wing. They might have clinics. They might have partnerships for like urgent cares, maybe even with some of the retail groups. They may have their own specialty pharmacy, and infusion sites. So any way that you think about healthcare could be delivered. And then if you want to add on to that with like a Kaiser, the insurance component of it too, right? So
Right.
organizations like Kaiser had their roots in managed healthcare. Then it's like cradle to grave. I forget who they used to say that about. Was it Sears? And of course, Sears
Yeah.
is Sears.
Yeah.
What's
I already have the
left?
life cycle.
Yeah, right. So you had the life cycle talk, right? So, but that's and so a lot of the conversation that people have when trying to understand these groups is, you know, how many how many different ways are they delivering care, and how truly integrated are the different ways of care? For example, you have a problem that gets identified by your primary care doctor. That doctor sends you to a specialist. The specialist determines that, let's say that, you have a non-threatening cancerous lesion on your face and that's got to be taken care of. And so then the derm sends you off to a surgeon that handles that. And maybe if you're in the Kaiser model, through work, your insurance is Kaiser. And so you go to a Kaiser facility and you see initially a Kaiser primary care doctor, then you see a Kaiser specialist and you get a procedure probably in an outpatient setting in a Kaiser clinic, right? And the degree to which everybody knows what everybody else is doing, and there's some planning and forethought and some measurement on the back end. So pretty typical management, business management things. That's one way that we assess whether a healthcare delivery network or IDN or healthcare system is advanced or not so advanced. How well are they communicating? How advanced are they technologically? Um, and so a lot of these kinds of questions we ask because there are some that think that if we project out 5 years, 10 years, whatever, um, that in the end we're going to have like a handful of these big delivery networks that are just today, depending on how you measure them, there are 600, 700 of them across the U.S. Maybe we're going to end up with a half dozen to a dozen that are going to be dictating how care is delivered and paid for in the US. So it is important to pay attention to them if you believe that that's kind of where things are trending, regardless of where they're actually going. So does that make sense? As
No, it
far as
does a lot.
explanation, anything you'd add to that in terms of my definition? I mean, that's the way that I look at them.
No, I love it. And I think we talked a little bit offline about it. We work with one of our clients is sort of community hospital, 500 beds, and it's trying to do kind of a variation at a clinically integrated network, but that's not really the same thing because they don't have that level of organization. And it's a tough model. And, going back to that example, they're in a major metro area and, there's now health systems all around them. And so, that's what the people are wondering about on the health side, right? Like, well, how many of these independent hospitals will survive? And then you get into things like you mentioned infusion. We have an infusion client. And so, like, there's natural progression of, okay, you've got gastroenterology. What about the infusion? Are you referring them out to an infusion center? Do you, have a affiliated oncology? Like, how does all this stuff fit together? And, you've come from a cottage industry of, hundreds of different players to private equity owned and also larger health system owned systems that we're all hoping there's some economies of scale and efficiencies by doing it that way, like versus, a sea of hundreds of different independent providers. So to me, this is fascinating for you watching it from your point of view. Um,
Hmm.
well, tell us about some of the trends you're seeing now with, maybe touching on all the stuff we just discussed, like
Yeah.
how that all work.
Well, I think, you know, the overarching trend, I don't know how many people would agree with me on this. Maybe this is just my bias, but I would say the overarching trend that we've been seeing over years is this notion of value-based care and the triple aim and things like that. Meaning paying for the quality of the outcomes rather than the number of services. We're in a fee-for-service world, right? So I would say that underneath everything that's going on, or maybe it's above, depending on how you want your picture, is a movement to get more value out of healthcare. Right? Would you agree with that? I mean, it's just
For
like that's
sure.
what we've been trying to do. We say like there's all this inefficiency in the system, all this waste. Um, and if we could just get more efficient and smarter about how we do things, and focus on the outcomes. Because I mean, think about it. Back in the day, um, I don't know what you were doing at that time, but let's say, early 90s, late 80s, when I was just starting to work, kind of becoming a professional. The everything was managed healthcare. Remember that managed care?
Yeah, for sure. It
Like
scared everybody. And
scared everybody. Oh, managed care, and and in some ways, people might have been right to be afraid because managed care. Look, their tool was just the scalpel. Their tool was to say, we're just going to deny care. And I'm overgeneralizing, obviously, but this is the knock on traditional managed care. We're just going to not pay for things. And if we don't pay for things, then we're profitable and we're holding down healthcare costs. Well, that's ridiculous
yeah,
if you think about it.
yeah.
And so, you know, some folks came along. It's largely credited to Don Berwick, and he says, it's not just him; it's a couple other guys too. But from the IHI came out in the early 2000s and said, you know, we want to improve the health of populations, um, and we want to improve people's experience with care. But we also want to hold the line on costs, and we want to do all that at the same time.
Right.
And for
Blame for clarity.
and triple aim, right? And so people said, well, that's crazy. You can't do that because we have this old notion, or I don't know if you even know if it's old, maybe it's an American notion, but we definitely, I think, equate price with value, right?
Yeah.
The easiest thing is, the BMW versus, a Honda or Peugeot or something, and then above that, you got your Maseratis and all these fancy sports cars. People say, well, I'm going to pay 200, 300 grand for a car because I get X, Y, and Z, and they associate that pleasure or the value. But when you talk about healthcare, it really kind of breaks down. And I think the biggest reason why is we're talking about life and death at the end of the day. and quality of life when we're around. And so the consequences of decisions around healthcare are so much bigger than consumer goods and some of the other things that we, do make our pricing models on, um, that it's hard for us to get our arms around. And I don't know what you think, Stuart, but I think it becomes even more complicated when you're trying to pay for value, when you're trying to put a dollar amount or trying to say, okay, well, this is the outcome that we want, and we want to pay for that versus, the way that we do pricing today.
Well, yeah, it's so hard. And, like I don't know if we talked about this last time, John, but I've always been, as a consumer, interested in patient experience, but I was invited to speak at Cleveland Clinic about a little over a decade ago about patient experience on their big symposium. They were really leading that. And my friend Jim Merlino's been on our podcast a bunch. And so like that's one whole category that, back then a lot of still, but back then especially, a lot of people, including doctors, like, I don't care if they like me. It's like, no, that's missing the point, right? It's a little deeper
Right.
than that. And then the idea of, keeping the cost per patient down, that goes back to managed care, but then improving the health of population, that's like, okay, now that's a lot. And then we start thinking about, when we talked about this sort of thing in the past on my podcast with various providers and different people, I always think about allergies and asthma. And so, it's like it's more than just giving them the right inhaler. It's like, well, if you go to their house, it's, especially on the lower income side of this, they've got dogs and cats and it's dusty and it's all running around. And, like there's just you would think this is really obvious that's going to help your kid, but it really isn't obvious to a lot of people. And like, how do we do that? And who's going to pay for that bill? But who's going to pay the bill in the emergency room? Like, there's a lot, right?
It's a
So
lot.
we all agree the emergency room is a bad idea. But so if you don't want to pay, $20,000 for that visit, maybe it's worth sending a social worker over there to help them clean it up once in a while. There's no easy answer. This is really complex and a mess. So,
Yeah, I
and
mean it's out of the box. Like I remember years ago, what was it, Montefiore, um, putting air conditioning units into a certain area in the Bronx where there were high asthma rates. And then, you hear about like food cooperatives that some of the health systems do, and some of the housing work that Kaiser and some of the other systems have done for homelessness. So it's like penny wise and pound foolish, right? We're gonna save money here, but if we don't invest in this over the long haul, it's going to come back to bite us. And so I think that's where a lot of that thinking comes from. Like, let's address some of the root causes, or get at the root. But that's not how health in general, that's not why people get into healthcare, or what doctors train for or nurses train for, right? It forces them to be kind of out of the box and their thinking.
well, I get, in talking to doctors, as I often do, especially back when I was leading seminars for them like every week, like I used to do. I would always ask, even the most sort of status quo doctors out there who felt like anything is just talking about socialism, when you said, would you design the healthcare system the way it is now if you started from scratch? Like, oh no.
Right.
Who would? Who would do that? Who would design the healthcare system from scratch the way it is now? Even like, I'm sure there's people out there listening to this who would say, I do, but most people I know, even the most conservative, status quo kind of leaning folks are like, yeah, no, that's probably not the best model ever. And that is, you're right about the training. It's like, things like palliative care, for example. Nobody wants to do palliative care. You want to get the patient better. You want to do
Sure.
1, 3 and get them better. And preventive isn't very exciting. Yet, if we're trying to look at the broader population, and broader costs, we need to think about that. So let's go back to trends. Like, what is the good news and bad news? Let's frame it that way. Like, since you started this and studying this seriously, like, what things are like, oh, thank God that's finally working, and what things are like, why is that still a problem? I'd love to know. What are your thoughts there?
I would say a couple of things, back to the trends. One of the disappointments for me, I'd say at this point, is the permanent uptick in telemedicine. And that if when we're coming out, if you remember, and I'm sure we talked about this previously, coming out of COVID and during COVID, there were a lot of people who did heroic things with telemedicine to be able to keep care being delivered in the middle of a pandemic. And so much switched to that. And, there was changes in reimbursement to allow for more telemedicine. It got people to where, right place, right time, right,
Mhm.
right. That those kind of conversations. Well, turns out people like to look on their phone or on their computer and have a visit. It's very convenient for them. There was a lot of hype and we wrote a lot about it here. I'm sure you did too. And, here as we sit in mid towards the end of 2024, I've got like a big yawn, like, well, what really happened? How much did it really take over? How much did the payment mechanisms really adjust for this? How much and so I don't think that it's remotely realized its promise. Um, Not just because we don't talk about it as much today as we were a few years ago. Um, on the other hand, something that does show a lot of promise and is probably, I said there's the overarching trend, but it's probably the number one trend, is the adoption of AI into various elements, every element really that you can think of in healthcare. It seems like somebody's testing this out. But the introduction of AI into not just clinical decision making or clinical support, but in population health, the financial sphere, in communications. I mean, it touches so many different areas that it's clearly, in my mind, the hottest trend. We've tried not to write about it. There's so much on it every single week that's coming out on AI. And I think, it's kind of, I don't know, I guess everybody sort of says this is, to some degree, that the jury is out. I don't think that people think the jury is out like AI is going to be gone in a few years. It's more like, well, now that we have this new technology, how do we refine it? Where is it good? Where is it not so good? And I think some of the largest systems and even some of the more medium-sized groups out there and physician groups are trying to figure this out, as well as the Googles and the Microsofts and the Apples of the world, still kind of in that game. So
So I would, so
the
let's go down to that a little bit. I'd love to get your feedback on the following. So, in terms of healthcare and the application, I can, with our positioning on the internet, I see a lot of things. I hear a lot of things. I get pitched a lot of things, right? And so some of the things that have been pitched recently is AI for the purposes of taking routine new patient calls, trying to help them navigate, or scheduling an appointment, or following up with patients for routine things. And I'm talking voice, not just text or email. The A venture capital based company did some work and was showing that the AI doctor that they had created was doing a better job of diagnosing patients than the human doctors. Because, the thing about AI is, at least in theory, you can control, like, it's going down a certain protocol. It's not prone to human error or bias, right? It's like step one, two, three, four, five will always be the same. And then if they say this, then that'll always be the same. So those are two areas. And then you look at cost control and, sort of accounting. You've got things like trying to find maybe hidden clues in the data where illness might be in a certain community. Like, those are just a few examples. Like, do you hear about any of that stuff, or is there other stuff? Like, where do you see the biggest, most common maybe groups of applications?
so I'm sure I don't talk to as many of these people, but I'm sure, like on the financial side, um, for instance, in just getting better and smarter with coding,
Yeah.
right? And maybe identifying, did we code this properly? And the kind of flags that would help out that are revenue generating potentially for that system. So I'm sure there's a lot of that going on. We just don't see it as much. Where I see it the most is in pop health and clinical decision support, and all of the realms of what could probably fit like 50 companies with offerings in this area that kind of fall under that. But back to your point about who makes the better decision. I mean, look, I'm not going to get into a matrix conversation about where we're headed with machines, but if you think about you know how does a doctor or a nurse, how do they make decisions? And don't they kind of go through, maybe not consciously, or maybe consciously if it's built into the EHR, but sort of a decision tree in their heads,
Yeah.
right? I see this, that means can't be this, so I'm going to go down this path. And and that's kind of the way I think they make those decisions, of course, prone to bias. And sometimes those biases, I think we call that learning and wisdom, could be a good thing that maybe we haven't quite marshaled in the AI age.
Yep.
Um, and then it's sort of on the flip side, the bad thing from what I hear, at least in just sort of like the chat GPT realm of AI, that if it doesn't really know the answer to something, it can make something up and sound really good, including references.
Yeah.
Right? Do you remember the story? What was it? The lawyer who had prepared some, I don't know, I don't remember. But it was relatively recently in the last year or two that everything turned out to be made up, even the references and that were put into the case law.
Wow.
So I'm very careful. You know, what in our world, AI is great for brainstorming, not so great for facts,
Yeah, for sure. Well,
right?
going back to what you said there a minute ago, like, so I think you mentioned, population health planning. And so I'm going to throw a scenario out there to you and tell me if this is something you've seen, because especially with sort of the IDNs. But like, if I think about, okay, if I'm looking as an IDN, where do I want to have actual physical facilities for care? That's a complex decision. There's
Mhm.
transportation issues, there's, the demographics of that area, physical barriers, mental barriers, because different areas have that too. Are we going to steal from other locations? That feels like the kind of place that is really, really complex that I would probably wouldn't rely on AI, but I'd sure like to know what AI has to say. Is that an
Mhm.
area where they're using it? It seems like it would be natural for the kind of work you're doing, or at least to hear you talking about.
Again, we also have to be careful here too, Stuart, because I don't know if you've seen this, but it seems like everything these days is falling under the AI moniker,
Oh, it's a sales thing, believe me.
right?
Yeah,
So if you're talking about I developed an Excel algorithm that maximizes the potential for visits, traded off with socioeconomic blah blah blah, and traded off with all these other variables, that's already being done. And I would think, I mean,
yeah,
you and I could sit down with our screens and a spreadsheet and probably fill out a pretty decent prediction just on that. So I don't know if AI is actually in that world, but I think, ultimately it's going to come down to um, I mean, there's some ethical issues, but I think right now, because look, I don't think on balance, there's some systems that do pretty well, but on balance, with the technology that we had available 5 years ago and 10 years ago, I don't think that these health systems are maximizing their efforts in population health and identifying the right patients, right? And so the newer technologies hopefully can help out with that, but they bring, again, a whole host of other things. So I guess my kind of a lousy answer, Stuart, honestly, but it's kind of it depends. And then I ask the question, well, is it really AI or is it just good analytical thinking that built a model that is a good predictive model?
yeah, that
It's
totally
just
makes
not the
sense.
same thing.
Yeah, well, it definitely has a lot of sex appeal, like I said. And I can see applications and all the stuff we discussed. But yeah, at the end of the day, um, we are figuring out it's not going anywhere. It's really helpful, in a lot of ways. Organizing the notes for the podcast. The writer that's going to go summarize this meeting between you and I will probably use AI just to get a start. She's not going to do it that way, but that's,
Sure.
part of so we use these tools in any way we can. So I want to go back to something you alluded to a minute ago. And my dog's, by the way, name is Pirate, and it's National Speak Like a Pirate Day. So there's that. He's right. He's speaking right now. It's pirata in Spanish, actually, but sorry,
Pirat.
those of you that are listening to the actual recording here. But let's talk about value-based care. And you didn't mention the sort of disappointment with that. So I'd say value-based care has been around now for a long time. And when I talk to people, leaders and clinicians privately, like, yeah, what? I mean, it's there, but I thought it'd be a lot bigger by now. Just like I thought we'd all be driving flying cars by now. And that hasn't really happened the way we thought it would. So give me a sense of, I asked you earlier offline, you had an answer to this. Like, what is the penetration of value care? Is there a percentage? How do you quantify that? Where is it now? Where is it
Yeah.
going? All that kind of stuff.
So it's really interesting. It's a question, some form of this question is something that I've been asking in research interviews for well over 10 years. And to your point, it's been around a long time. I think I said 10 or 15 years or something. The concepts have been around longer than that. I mean, we were having our conversations back in school in '06 and '07. So it's been around a while. Um, I think there are good reasons for this, but I don't think that it has really met the promise, at least sort of like where people thought that we would be. And I go back, and I don't remember if I mentioned this last time, but it's really it was a really kind of a seminal moment for me. I go back to, 2013, 2014 timeframe, around that time, as I said, when I'm trying to figure out where this company was going to go and what we were going to focus on. And I went to a lot of the conferences back then that were really focused on value-based care and ACOs and, some IDN stuff too. And the people back then, so you figure 10 years ago, um, these conferences were on a scale relatively small to ones that we normally think of, but they're specialized conferences. So maybe say there's 1,000 people there, maybe 750 people there.
Yeah.
And these are like, these people drank the Kool-Aid. They were totally, 1 billion% behind value-based care and wanted to talk about what they were doing. And a lot of these guys, I bet, looked a lot like your clients. So there are a lot of physician groups, a lot of really strong, like entrepreneurial physicians that were moving their organizations in this direction. Maybe to your point, putting together clinically integrated network on top of everything, bringing other doctors into the fold. But every time I read a paper, every time I see something come out, Avalier does an analysis of X government program in healthcare and how they did. And I just want to yawn, right? The numbers,
No, tell us what you
the
really think, John. Tell us what
I,
you really. I love it.
but I mean, it doesn't mean that I'm not a fan. It doesn't mean that I don't think it's cool and that we shouldn't be moving to extract more value and there isn't waste and blah, blah, blah. I get all that and I'm on board. But, and you look at it this way. So, and this is what I saw 15, 20 years ago with the ACO model. You have a situation where you have an entity, let's just say a big physician group. They go to Medicare and they say, we want to be an ACO. Great. You did all your paperwork. Great. And at our core as an organization, we follow the triple aim. We want to improve the health of populations, reduce cost, so on and so forth. And as part of this agreement, Medicare says, sorry, I'm going to do a little quick 101 here. I'll try to do it quickly. Medicare says, here's your budget. Here's how much money we think you're going to spend. Talk to us in 18 months, how much money that we actually reimbursed you. And if there's savings there, I'm really simplifying this, but if there's savings there, we're going to share in that savings. And so let's say it's 50-50 split. We said you were going to spend, $100 million on care for your patients. You only spent 90. And so there's a $10 million difference. And so let's split that 10 million. We'll give you physician organization, we'll give you 5 million. Great. And we'll keep, as the government, we'll keep 5 million. And that's sort of a shared savings model. And we can talk about risk and, quality and other things that go into it, but that's sort of the basic gist, right?
Yep.
And so, but if you break down, if you look at that $5 million, which seems like a lot, and then you say, well, according to our charter, 60-75% of that has to be reinvested in the organization for technology, for improved care and all of that, right? So now you're $5 million. Now you're down to, let's say, even $1 million, which is probably more realistic, right? Once you've done all those other investments. And let's say that you've got, a few hundred physicians in your physician group, or let's say you're an IDN and you're dealing with, hundreds of millions or billions in net patient revenue overall, and you've got, 2,000 docs that are under salary and another 2,000 that you're contracted with. That number, right? So it starts to look really small. And the doc that was in that practice or part of that network, part of that ACO, looks at it and says, okay, well, I upgraded all my computer systems. I had to hire two more people that I didn't have before because I've got to manage this process. And they have to have a little more experience than the other person that I had as an office manager. So I've done all of this. I'm also seeing more patients because I figured out how to become a little bit more efficient. And I just got a check for $450 from the ACO,
Woohoo.
right? So I'm making a big deal out of this, but if you look at the numbers and look, some of these convening organizations that put together the bundles that do the bundled payments, and some ACOs, there's one in Florida that year after year seems to have 50, 60, $70 million in share savings. They seem to be killing it. But what is the net effect? The only thing that I will say at this point, I'm dying to hear what you think too, Stuart, on this point, but the net effect, I think at this point that's positive has been an overall change in attitude. And I've said this from the very beginning about the ACO model and value-based care models in general, that if you can get people to shift their thinking from, I'm going to save money because I'm going to just not approve this procedure, I'm going to cut costs, versus I'm going to focus on outcomes that will lead to savings if I do the right things like preventive care and some things you mentioned. Well, if there's that shift in attitude that helps us in the long run, I think that's a good thing. But as far as the actual results that I've seen, and in terms of real impact on the cost side of things, not a lot.
Yeah. So it's funny, like we were involved, um, sort of tangentially with one of the pioneering ACOs, and like a lot of those really did get arrows in the back, right? And so
Yeah,
I didn't follow it. I don't follow this anywhere nearly as close as you do, but I know a number pulled out and they brought ones back in, and that's a whole thing. All you're done with the
yeah,
government, a lot to that whole story, way beyond the scope of this call. But I do remember, and even as recently as we were talking to a major health system in Florida recently, if you just come back to like how do we keep people out of the emergency room, like that's the big driver, I think. That seems to be like, okay, practically speaking, at least from the marketing side, how can we do our part? And it's like, well, let's keep them healthy. And especially, and then if you're looking at the 80-20 rule, the Pareto principle, like, okay, generally keeping people healthy is like, okay, it's ambitious and broad, but usually you're going to find 1% of any population is going to be responsible for 50% of the results. Let's think about that and figure out how to keep them out of the emergency room. Might be a way to do this, but I'll put that aside. And then going back to, wow, I love the way you just broke that down in terms of the numbers. Knowing the doctors I do, boy, that would be less than a collective shrug. Like, wait, I lost money. I lost a lot of money by
right.
doing this. And
Exactly.
so, ethically, I like this, but man, I'm working really hard. So I guess then, like, let's say, there's an election coming. You're now they appoint you as the czar of this topic, which they could. You know a
Yeah,
lot.
they could. They could.
So what would you do? Like, how would you make things better? What can you do? What's a realistic goal? What's like not a realistic goal?
Well, boy, there's a another hour or two on this podcast that we could pontificate about this. Um, I am for non-political, non-ideological reasons, because I'm going to preface that because for some reason, if I say this, then everybody's going to take it politically. I think some form of, for lack of a better term, a Medicare for all is ultimately where, as a nation, as a society, where we're going to need to be.
Yeah.
And I say that with, understanding that, especially from the world that I came from and that I grew up in, that's like a major heresy to say something like that, right?
Yeah. It's the only
But
polite company ever.
yeah,
Yeah.
but if you just sort of take out, the whatever political nonsense that you've heard over the last 20 or so years or 30 years or whatever you know, and you think about it, a lot of the inefficiencies that we do have in healthcare have nothing to do with, or we can't innovate our way out of it necessarily. the inefficiencies that are there are structural. And one of the biggest ones, I mean, we could talk about, PBMs, right? On the pharma side, we can talk about PBMs and whether that's a market distortion, if it's a good thing or a bad thing. But there's so many of these things that I think we'd solve a lot of problems with, and I'll give you a more tangible example why I say this. We'd solve a lot of problems by having a more unified payment structure and not having to introduce the concept of competition in the way that we do today. Like the way we have it now with the Affordable Care Act and the old Heritage Foundation model that became Obamacare. It's a good interim step, but I don't see it as being the end goal. And the example that I was going to use, we did a project for a client that was, and this is a pharma client that was looking to essentially implement a money back guarantee for across the board for all of their products. Have we talked about this? I mean, I'm trying to
No,
think
I
if
don't
we've
think
had a
so.
conversation. I don't think that we have. And so basically, if our product doesn't work, if we have something that lowers cholesterol and your cholesterol is not being lowered, if we have something that is supposed to grow hair on your head and it doesn't grow hair on your head, whatever. And obviously, I'm using simpler examples, but it becomes much more difficult when you're talking about heart attack, death, cancer, a bunch of other things. But this is the value proposition that if you use our product and it doesn't work, we're going to give you money back. And so so very much so a pure value-based contract. The goal is you want these better patient outcomes, and not just better, but if there isn't a positive outcome that is expected, then don't use the drug and we're going to give you your money back in its very simplest form. So perfect example of a value-based agreement. The problem is, well, the first question is who gets their money back? Does the patient who did a copay get their money back? Does the IDN that has the patient under their care get their money back? Does the payer, which may or may not be the IDN, get the money back? And oh, by the way, what if they're a Medicare patient? They're not. And what if they're Medicare and they're part of an ACO, or they're Medicare and they're a Medicare Advantage? And you start going down this road and you see in the comments that we got, spoiler alert, people didn't like it. So I did about 30, 35 interviews with people and ran through this model with very knowledgeable people in healthcare and who are delivering care or paying for care. And it was almost universally panned. And a lot of it had to do with this question of, well, who gets the money? And one of the recommendations that I gave to our client, one of the positive recommendations, should they want to go forward with this, is what I said was, or where our company landed was, this kind of model is only going to work in a Kaiser or a Geisinger or any health system. If you're going to do it in a health system and not just with a payer, it's got to be done in a health system where they have the total cost of care under their umbrella, so they're a payer as well, so that it makes financial sense for them to track these outcomes. They might have the ability to track the outcomes better, but otherwise it just becomes so difficult to implement. And so the process of measuring all of this costs more than any potential savings could possibly be, with a lot of headache involved.
Yeah.
So
Also, you would take the incentive for the pharma, for example, out. Like, wait, we're going to spend all these billions of dollars to develop a drug, and we may not get paid. So that makes it hard too. That's a little barrier to entry. Like, okay, you go do that then.
yeah, and
Take on that risk.
even if they stand by their product and they say, well, we know our product is good, there's the potential upside for that company, right? Because their competitors that aren't under this agreement, well, maybe whoever has that value-based agreement says, we're going to use more of the product where we know that there's this money back guarantee,
Yeah.
right? And so maybe they could grow their pie a little bit more. But that's why I say that, when we're talking in these terms, I really feel like, and if it's not a single payment type system, then it's something a little bit more that approximates what I talked about before, which is a fewer number of health systems to be able to sort of control the pie.
So perfect. This is really fascinating. So as we wrap up a couple more things and we'll save it for the next time.
I haven't put you to sleep yet, Stuart, all
Oh
this
no, I
stuff.
love this stuff.
It's
It's like really fun. I love anything that's like forward thinking about healthcare, and it's like it's important to keep the vision of what's possible and not get too sort of downtrodden because it's
yeah.
pretty glacial at times. Like for all the changes, there's some things that are like you said, it's like going back to what I said a little while ago. Would anybody design it the way it is now? Because with that creates all these other unforeseen, unanticipated consequences. And it's like you can totally get political there too, but it's like sometimes things evolve. You have to start over or figure out something because if you're doing incrementalism, eventually it just stops working. And that's I think kind of where we are in some ways. So going back to the pharma and life sciences, how does pharma view IDNs in terms of research or other partnerships? Like what is pharma thinking about? They're paying you, they must care. So like what are some of the conclusions there?
So the old school model still exists of how companies market and sell their drugs. So if we just look at the pharma component of the biotech sort of component of life sciences, the old school way is you have a sales force and then you go send in a rep to go see a doctor. They talk to that doctor about the product, they educate the doctor, and they sell that doctor, right? And that model for pharmaceutical marketing worked for a lot of years. Um, Not so much anymore. And there are a lot of reasons for that. One of them is that I think the industry sort of shot themselves in the foot in the 90s and the early 2000s by hiring armies of sales reps and doubling down and tripling down and quadrupling down on certain physician offices where at some point they just kind of threw up their hands and said, enough with the onslaught of reps, right? So there was that dynamic. But the other dynamic, which is maybe even more important, is the acquisition of these physician offices by IDNs from private equity, from insurance, from like Optum. I mean, what are they up to? 100,000 doctors or something like that at this point. So United Healthcare, Optum. And in those circumstances, after post-acquisition, um, almost by definition, the access gets shut off because these systems want to control, or these PE groups or these insurance companies want to control how their physicians and their nurses and everybody else, how they spend their time. And the last thing they want them doing is spending time with sales reps. So they immediately will shut off access. And so the question that has been on pharma's mind, I think probably for over a decade at this point is, okay, if now as the business is shifted to these big physician groups and these IDNs and all of this, how do we keep marketing our stuff?
Right.
Right? We can't just leave it to the peer-reviewed journals and let them figure this out on their own or figure this out on their own at conferences. So how do we market our stuff? So the first response, which they did, I don't know, 20 years ago plus, is to say we're going to bypass all of this and we're going to pour oodles of money into direct-to-consumer advertising, right? You cannot watch
Yeah.
TV at this point for any duration of time beyond 5 minutes in a commercial break without seeing a drug commercial.
Yeah.
They're
Yeah.
everywhere. So
Yeah.
that's first thing. And we're gonna create demand by having patients go into the doctor's office and demand our product, right? And and that I think is pretty effective. But then the other thing they said is, well, how do we align our sales force to work better in this new environment? And I think what a lot of them have what they've come up with is more of an account management model where they have more experienced people doing having building relationships and having meetings. And so instead of having 2,000 reps, and I'm oversimplifying here, maybe they have 25 account managers and 100 reps or something like that. But the question is, and the struggle is, if you look at pharma from an IDN's perspective, or a big physicians group perspective, they still have the negative thoughts. They still have they remember the armies of reps coming in and disrupting their workflow. So that doesn't go away overnight. Then the question is, okay, well, what value can you bring to us? Do you really bring to us? And how can we work with you in kind of a different way? By the way, I don't think IDNs are asking that question. I think pharma is asking that question of what they can do for
Yeah,
IDNs,
yeah.
and then trying to, have the question come from the IDNs. Because again, as far as the health system or the big physician group or the big cancer center, what they understand the life sciences to be is a test bed of innovation, research, clinical trials, things like that, where they have the capabilities. And all of that makes sense. Okay, Pfizer's developing a new drug. We want to be on board with that. We want to be one of the sites or one of the partners in evaluating that drug. So I think where we are now is kind of at a standstill. And I swear I did not intend for this to come across. It's going to sound like I'm giving you the big wind up for a promotion. I don't mean it like this,
Oh, please,
but
God.
I don't mean it like this.
No, no, no. Please promote yourself. I want someone to
So
call.
I'm just So we're in the
Do.
process of we're launching a national IDN engagement study, um, something that we did in the wake of COVID for about 18 months, and now we're kind of restarting that. The environment is different. We're not asking questions around COVID as we were before, but we're really trying to get at this partnership or collaboration or engagement piece that identifies the win for the patient, for the health system, and for the pharma company. What does that look like? What does working together on something, on a project, collaboratively do to improve patient outcomes?
That's
And
exciting.
it's exciting. It's a big question, and I think that's kind of where pharma is today. I think there's a lot of head scratching. I think some people said the common refrain that I get all the time, Stuart, is the wins that we have, the WINS, not WINDS, the wins that we have are very rare. We can point to one or two partnership, collaboration, agreements, whatever you want to call it, and maybe a value-based bit component to that, where we can all say that we were successful, that the patients turned out better, the system was happy with the results, and us as a life sciences or pharma company, we ended up winning out in the end as well too. Very, very rare. So we're in the process of launching this. We're going to be fielding, doing all the research in Q4, and are going to be releasing our results in January. So
All
I'm
right.
pretty
Well,
excited about it.
when you're ready, you have to come back and we'll
All
team.
right.
And I think that's intriguing. So I love this has been a very sort of intellectual, forward-looking, which is, to me is really fun, right? There's the day-to-day stuff, and for us, this is something that I love thinking about where things are. Like I said, try not to be despondent for some things that are really
Yeah.
difficult to change and still find daylight in the opening. So, as always, John, pleasure. Thank you for your time today. We'll talk again.
This is great. And I got to say, Stuart, one last shout out to you, because you make this so easy. You really do. And it's not easy. I hope that I'm easy on my guests too, but you're just, it's such a pleasure. I could come on and talk to you all the time. It's such a pleasure doing this. And it's because of the way that you go about it. So I really appreciate that. And thanks for having me.
You're welcome. Absolutely.